Good evening. I thank Sheel for having invited me to give a talk on this new perspective. When we talk on male infertility, one third is males are responsible, another one third females are responsible, and in the next one third, it is both male and female are responsible. So, if you can think about male infertility, 50% of the cases male is informed. If you look at that female, if you have a tubal factor, you have an ovulation factor, you have a peritoneal factor, and there are various cervical factor, immunological factors, there are unexplained infertility. Whereas if you, even though there is a long list of male infertility, most of the things are idiopathic where you are not able to explain. So, what is our aim? Our aim is to make sure they conceive at the least technical point. For example, you have natural conception, you have a ovulation induction and conception, you have an IUI, you have an ART. Our aim will be to see that they conceive at the least a technological support, and then they try to get into a normal pregnancy. So, as I have just mentioned it, in a idiopathic male infertility, we really don't know where to attack, where to treat, whether this works, whether that works. So there are various pathways, various things have been done. So ultimately, what is the aim we are aiming at is only improving the male factor. So we have to have some drug which has an effect on improving the all the parameters and then the improving the physiological function of the sperm. So that we have been talking very high about myoinositol in polycystic ovarian disease and in anovulation in female infertility all through. But we have come to know that it has also stood the test of time in male infertility and how it is going to impact. The key structure in male infertility is reactive oxygen species. The most prolific source of this ROS in sperm suspension is a nicotinamide adenomyxin dinucleotide phosphate, which NADPH. So this is located in leukocytes in spermatozoa that produce superoxidase that is further converted to peroxidase by the action of superoxide dimustase. So this is a complex situation. What we need is there has to be a scavenger system for the ROS to be cleaned up periodically. The hydrogen peroxide has been recognized as the most toxic oxidizing species of human spermatozoa, which are very sensitive to lipid peroxidation owing to the high content of polyunsaturated fatty acids in the plasma membrane. So this mechanism will impair the sperm function to a greater extent. So the impact of ROS on motility, morphology, and DNA stability. So if you look at the endometriose, the mitochondria are the organelles producing the energy, and they require ATP, and then they for their performance and function. However, ROS may induce changes in the mitochondrial membrane, may thus compromise on the sperm function. It has also been shown the mitochondrial membrane potential MMP and ROS levels are inversely correlated. Higher the levels, infertile is the patient. Lower the levels, fertility is high. Such relation should be due to the two mutually interconnected phenomena. On one hand, ROS causing damage to the mitochondrial membrane. On the other hand, damaged mitochondrial membrane causing ROS. So it is something like a cyclical phenomenon. So, what are the reasons for ROS damage during the spermatogenesis? We have sperm chromatin condensation, which is a process that is very susceptible to increased oxidative stress. Spermatozoa have very low DNA repair mechanism. However, the oocyte have got an excellent DNA repair mechanism. That is the reason if there is a DNA abnormality in the sperm, when you do an ICSI within the oocyte, it gets repaired and then results in a normal well-being. So the sperm membrane contains very high levels of polyunsaturated fatty acids. The spermatozoa themselves produce ROAs, especially during the passage through the epididymis. That is the reason if you have a very high ROA sperm, when you just try to take it from the testicular sperm, it will be more effective. However, if you take it from the epididymal aspiration, still the ROS activity will be there. Spermatozoa have a low levels of cytoplasmic oxidative systems, and usually most of the antioxidant enzymes are lost in the spermiogenesis. Spermatozoa spend long periods of isolated cells in both male and female genital tract. So you know that oocyte gets matured in about 14 days, and its life is only between 2 and 8 hours. Whereas in spermatozoa, the cycle is 72 days, and at least it stays about more than 48 hours there. Low myoinositol levels within the epididymis and in seminal plasma are associated with reduced fertility. This has been proven in the Journal of Andrology. Now let us see what actually happens. The glucose is there. They, with the actions of insulin, it is converted into a glycogen, and then it is converted to ATP, which gives the energy to the cell. However, the myoinositol acts as a second messenger here, acting directly on the glucose to glycogen conversion system, thereby increasing the incidence of fuel mechanisms there. So myoinositol, the myo concentration is significantly higher in seminiferous tubules than in serum. So in males, the reproductive organs, myo is mainly produced by Sertoli cells in response to the FSH stimulation and is involved in the process that include the regulation of motility, capacitation, and acrosomal reaction of the sperm cells. The myo may play a role in osmoregulation of the seminal fluid. Indeed, both hypo and hyperosmo medium have been found significantly decrease the sperm progressive motility and velocities there. So, an increased amount of particulate enzymes, inositol monophosphatase, IMPA1, is involved in the dephosphorylation of this PTTLNS, which has been detected in the astinospermic patients there. Therefore, it is possible that increased expression of IMPA in astinospermic patients could alter the PTDNL signaling pathway, thereby induce a reduction in sperm motility. So this sustains the role of signal transduction pathways induced by the PTDLN in the regulation of the maintenance of the male germ cell motility. The myoinositol acts directly on the mitochondria, increases the membrane potential. So if there is an increase, the membrane MMP is an apoptotic marker clearly related to the functional parameters of the sperm cells, including motility, capacity of the fertilization, and embryo quality, is therefore used as an index of fertility. High values of MMP indicate integrity of the structure with optimal levels of activity or associated with high cell viability. So the quality of the embryos will be there. If you look at the astinospermia and myoinositol, on one side, absolute astinospermia, you always go through an ICSI. If it is a relative astinospermia, where the progressive motility is less than 32%, total motility is less than 40% as per the WHO criteria, you have to exclude male accessory gland infection, leucospermatozoa, and the papillomavirus virus infections, and semen high viscosity, and lower testicular volume, hormonal alterations. Thereby, when you complete it, you have an evaluation of a mitochondrial membrane potential. If it is normal mitochondrial membrane potential, they go through the normal pathway. If they have a very low mitochondrial membrane potential, probably these are the people where they will be benefited from myoinositol. If you look at that freshly ejaculated spermatozoa as incapable of or poorly capable of fertilizing a oocyte, And the fertilization aptness of spermatozoa depends on appropriate time and time-dependent acquisition of the three important biological processes. What are the processes? They are capacitation and hypermotility, chemotaxis, and then acrosome reaction. All of them are based on calcium and ion oscillation, which is dependent on myoinositol. The spermatozoa of the patients with OATS are covered by amorphous fibrate material that increases the seminal fluid viscosity, thereby it reduces the sperm motility. Furthermore, the mitochondria in the intermediate tract of spermatozoa of the patient with OATS had a damaged cristae. However, after supplementation of inositol, the amorphous fibrous material disappears and the cristae damage is decreased. So that's how the fertilizing potential improves there. You look at here, this is the epidermis where you will see structures like that where the proteins and carbohydrates are secreted as a yellow teas here. So they are all stuck on the sperm. Whereas if you look at the ejaculated sperm, which is highly, more or less, it will be just like this. However, when they get capacitated, there is a space, there is an area where you will be able, this acrosome can interact with the oocyte and then they can work through. So this process of activation is brought about in the presence of this. Second is the chemotaxis. Chemotaxis is it plays an important role in the fertilization, particularly natural conception. It refers to the directed movement of the sperm towards the oocyte. The oocyte releases chemoattractants. For example, it releases an attractant from which, whatever is the pathway, it goes through the path closer to the egg, and that is what it is called as chemotaxis. Third is the acrosomal reaction, where it acquires the motility during the epididymal transit, becomes able to migrate from vagina to the fallopian tubes to penetrate the cumulus oophrus and carry out the process of involved in the fertilization. At first, after penetrating the cumulus oophrus of the sperm at the ovum, the spermatozoa binds to the zona pellucida with its plasma membrane intact. Then it undergoes acrosomal reaction. As a result, the release of hyaluronic acid and indiges the zona pellucida, allowing the spermatozoa to penetrate into the oocyte and then enter inside to fertilize it. These events are allowed by inositol and particularly by increasing intracellular calcium releasing through inositol gated channels because of the protein kinase PKC pathways there. So this is how the acrosomal reaction takes place. Initially, it goes here. Then once when it just goes closer to that, it gets attached, it neutralizes, dissolves, and then this enters inside with the cortical granulate contents there to get fertilized here. This is the very important fused plasma membrane here. So this acrosomal reaction needs calcium. So calcium signaling that events that mediate the acrosomal reaction from the cell membrane and from the TRPC calcium ion channels through the ZP receptors there. And there is an increase in calcium levels in the sperm cytoplasm. So this leads into the acrosomal reaction. You look at this data, the effect of myoinositol on sperm mitochondrial function has been just given up there. The concentration of myoinositol in the seminiferous tubule is higher than that of level seen in the seminal plasma. So another important point is myoinositol decreases the DNA fragmentation. The impact of in vitro the semen supplementation with myoinositol upon DNA fragmentation was addressed in a cross-sectional study done in women presented at about 2015 X-ray meeting. And there they have just highlighted the report saying that significant overall decrease in DNA fragmentation was determined in a myoinositol treated sperm although not expanded to a larger group. So I've just seen it in a small group. So there is another clinical study, Mayones et al., on idiopathic infertility, where, so this is again a study from Italy, there they've evaluated that. What was the study? It is a double-blind, randomized, placebo-controlled trial. It has taken place in Italy. Number of participants were about 194. Mayones et al. On 98, placebo on 96. Dose was myonestal 4 grams per day, duration for about 3 months. And it was published in American Society of Andrology in February 2015. It's a very complex data. So here you will see here, this is myonestal group, this is placebo group. This is before treatment and this is after treatment. If you look at the levels of testosterone, which was 15.8, has come to 18.6, thereby showing, and the sperm concentration was 20.2 before, and after treatment, it is 26.4. Total sperm count per ejaculate was 46.6 before treatment, and it is 57.6 after treatment. Progressive motility was 22.2, whereas after treatment, it is 27.2. And here, the acrosome reacted chromosome percentage was 34 before and 41 after. Whereas if you look at the placebo, no difference between before treatment in almost all the groups there. Shows it is a myonestal, definitely has got a positive role. This is another study from Italy where they've just seen the effect of myonestal and antioxidant on sperm quality in men with metabolic syndromes. So here you will see this is a concentration before treatment and after treatment. What was there at 16.2 has come to 20. The motility of 39.6 has become 51.4. Normal morphology was seen in about 24.9, which has become 30. So both the studies which has been done in Italy proves beyond doubt the role of myonestal in male infertility. To summarize, male factor infertility contributes to half of infertility population. In male infertility, more than half are idiopathic or unexplained. Efforts have been taken to medically postpone the ART or to improve the results before ART. All medical methods have limited success. Myoinositol is a new concept in male infertility. It is only a micronutrient which is supposed to be very useful, and it is worthwhile taking a large trials to publish the data from our Indian study. Thank you very much for your patient listening.
Yeah, thank you very much, sir, for your excellent talk. It is always an honor and learning to hear you, sir. And sir, if you allow me, then we will have a Q&A session.
Sure, sure.
If there are any questions, I'll read out for you, sir.
Yes.
Yeah.
A lot of people are waiting before ART. It takes about 1 year for the cycle, and then one month, one cycle for the preparation, one cycle for the treatment. Simultaneously, the men with oligoacinoteratospermia who have been waiting to get into the line can always be supplemented with myoinositol, and then it's worthwhile trying. Particularly a patient with metabolic syndrome, it is worthwhile trying it there.
Sir, I have a question for you, sir. And
Yes.
when do we prefer the testicular biopsy?
Yeah. So when it is a case of usually testicular biopsies have been done left and right before, but nowadays it has been restricted. Number one, in a normospermatogenic cycles, there is no place for testicular biopsy if the motility or the other parameters are very poor. Second is, in oligoacinospermia, if you do a testicular biopsy, you are breaking the blood testis barrier, thereby increasing the anti-sperm antibody formation. So you should not do it. In case of azoospermia, Just to make a diagnosis, you don't have to do a testicular biopsy. You do an FSH study that will tell you whether it is obstructed or non-obstructed azoospermia. Look at the size of the testis, volume of the testis, blood flow to the testis. All of them will tell you. Then we have a simple genetic testing called Y chromosome microdeletion. If the Y chromosome microdeletion is there in A and B, you cannot retrieve anything out of the testis. It is not worthwhile touching the testis. And if it is only C is involved, you can't retrieve. So in that case, you have to do the testicular biopsy in the ART center where the wife is supposed to be going through the process of IVF. You should not do a biopsy in the general laboratory and put the testicular tissues in formalin and send it for biopsy. There is a very limited, restricted role. Only to retrieve the sperms, you can do a testicular biopsy.
Thank you, sir. And sir, we have one more question. That is, what is the percentage of live birth that we can expect from the corrective surgery for varicocele?
Yes. So varicocele, number one, it is a mild, moderate, severe. So this mild and moderate, normally we do not do any surgery. In a severe, we do the surgery. So in severe, it can be done in oligoasthenoteratospermia. It can be done in non-obstructive azoospermia, in obstructive azoospermia. When you try to do the surgery in a varicocele, your chances of getting a pregnancy is about 38 to 40% following that. In a case of oligoasthenoteratospermia, when you have ruled out all the other probabilities. In an obstructive azoospermia, it is debatable. Many people believe that it can improve the results by about 25 to 30%. But however, we follow, whenever we are trying to do an ICSI, we do not advocate the varicocele repair in a non-obstructive azoospermia.
Thank you, sir. And sir, we have one more question. Like, if a obese patient who is having infertility and doing excessive exercise, because we know that the excessive exercise is an causative factor for the infertility. So, what we could advise the patient for in exercise? I mean,
I think it is relevant to the male patient.
yes, a male patient.
Yeah, male patient, obese patient, they cannot go through a strenuous exercise, but they can go for a regular walking diet, and then with that they can just try to reduce. The more of the fat produces estrogen, it alters the estradiol testosterone ratio, thereby it alters spermatogenesis. So they have to reduce, they have to go through a rigorous walking, at least 45 minutes a day for 6 days a week, they have to go through it. Alternatively, if they have some kind of a oats cases where the ratio is altered, you have increased testosterone, then probably you can just go in for a letrozole 2.5 milligram on alternate days for about 90 days, or clomiphene citrate 25 milligram on alternate day for about 90 days, and that will help you to bring down the estradiol level and improve the testosterone level. Thereby, it will improve the sperm count. There's another question which has just come out. What are the investigations needed in the male infertility? Count is 5 million. Non-motile is 60 to 60. Scan varicocele left first degree, right 3 degree. Is varicocele correction needed? It is a case of oligoasthenoteratospermia. My first line of management will be to treat the male accessory gland infection. I would prefer to repeat 3 courses of antibiotic like clindamycin, doxycycline, azithromycin, one after other, 3 cyclical antibiotic. Along with that, some NSAIDs, and along with that, I will ask this man to go in for frequent ejaculation. So after this, I will evaluate and see whether it has improved. If it has improved, fine, well and good. If it has not improved, I will give them an option. If the patient cannot afford ART and ART is not in their line at present, then I will offer them varicocele correction.
Yeah. Thank you, sir. Sir, sir, I don't find any additional questions in the comment box. So if you allow me, then we will close the webinar.
Yes, ma'am. Thank you.
Yeah, thank you, sir. Many thanks from the Shield team, sir. Thank you once again, sir.
Thank you.
Yeah.